morning. Thank you all for coming back to Rock Health Summit. My name is Zweig. I lead research for Rock Health. Super excited to be here with Mario from Oscar. I told him that we each had to come with a fun fact. So I'll go first. So my fun fact is that my mom actually is an Oscar member, and I get text messages from her all the time about how many steps she's taken that day, and Oscar actually provides a financial incentive for her to do so. So I get these screenshots all the time of the money that she's earning from Oscar, and I actually decided to text her this morning and tell her that I was interviewing you, and she said, oh, my health agent asked if I wanted to continue with Oscar. I said yes.
All right.
She said, I like the ease of looking up doctors and communicating with Oscar. I just need to stay healthy.
Okay, very good. We'd love to hear that.
So yeah, wanted to thank you. I love that you've engaged my mom because I didn't even know she knew how to download an app, and yet she's regularly using Oscar. So
that's
thank
great.
you.
Thank you, and that's great to be here. And I mean, that's fantastic to hear. In California, just since yesterday, I think members can now renew their plans. So I'm glad your mom is
She's gonna do
the
it.
first one out the gates there.
Yep.
That's good.
So your fun fact.
Yeah, oh, my fun fact, exactly. Great. So I think mine would be that I have always, in a weird way, associated numbers with colors and letters with colors as well. I think there's like a phenomenon called synesthetics. And that's one thing where, since the beginning of Oscar, I've been trying to search for that in the Oscar app. We still don't have a good sort of like care pathway around what that should mean from utilizing the healthcare system from that perspective. So it's a fun fact there. So
Yeah.
we're covering everything. Just
Eager to see where that goes.
Exactly.
Awesome. So we have a lot to cover. Obviously, Oscar raised a large fundraising round this year. You've made announcements about entering the Medicare Advantage market. You're kind of entering other markets on the Obamacare exchanges, so we'll cover a lot of ground. But I wanted to start, I know Oscar is self-described as kind of insurance centered around the patient. So I wanted to start there and kind of ask about, how do you think of Oscar and the customer experience relative to kind of other health insurance companies?
Yeah. We started the company in 2012, and the very simple idea at the time was that there wasn't really anybody in the healthcare system, which is both too complex and too costly, which we all know, who had the end-to-end visibility of you as a member navigating, as a person navigating healthcare. From a data perspective, and neither had the incentives to sort of like really help you navigate the healthcare system end to end, except for the insurance company. The insurance company gets the bills of everything you do in healthcare at some point. It has a chance of sort of like helping you through that system. And my experience in 2012 certainly was that the insurers I've had in my life never really seemed to pay much attention to me as somebody needing advice on how to utilize healthcare. And both in terms of getting to better outcomes and lowering the costs I would face in doing so. We were going at the time through pregnancy with my first kids, my wife, and my son Noah was born in August 2012. And so all of this really sort of like had a very real-time and real-life feel to me, because we're trying to navigate healthcare for this particular purpose. And as a result, we said if we could become an insurance company and essentially become the ultimate insider in the healthcare system, which is what the insurance company really is. It sits at the heart of data flows, dollar flows in the healthcare system. It can decide on benefit designs, what it reimburses providers. If we could become that, it would be a very powerful place to be, and a powerful place in which to engage members in a different kind of way. And so the overarching objective, in a sense, we have is to maximize the share of someone's healthcare experience that we can shape directly or indirectly. That's really the overall Oscar objective, and that means helping you find physicians on the one hand, but on the other hand, knowing when you might be looking for physicians, even being more out in front of that, making sure you know what needs to get done after you went to a physician, had a conversation there, and helping you ideally over decades of you being a member, how to get to better outcomes over time.
And I know, because there are a lot of tools, you've already mentioned some for the consumer experience, but you're also building out tools to help providers. So to give them insight into information on their patients, helping with clinical decision support. How do you think about investing in kind of the consumer facing experience versus investing in the provider experience?
Yeah. I think it goes back to a high-level point, which is that when we started, we got known for example, the feature we launched in late 2014, which is we paid you money for walking steps, and that wasn't that common at the time. I think, were the first insurance company to offer free telemedicine. You click a button, doctor will call you back, chat with you, whatever. That also wasn't common at all at the time. I think we were the first insurer to really make that totally free and ubiquitous. That made people think that we are primarily investing in just the member experience. And I still think we're far ahead on the member experience side of anybody else out there. But the truth also is, behind the scenes, we invested a third in member experience, a third in the provider experience, and about a third in just back office stuff. And that's, I think, starting to pay off now 5 or 6 years in, because we have a lot more control over what we do internally, what we have built internally, because we have got this full stack technology sitting underneath all of this. On the provider side in particular, as you asked about that, there's sort of like two things we try to do there. On the one hand, we try to make providers' life easier. There's a recent survey, and I think a great Reddit discussion even on that survey, that something like 55% or so of physicians now have essentially suffer from burnouts.
Yeah.
The amounts of complexity that's weighing on the individual physicians, actually partly from a shift away from fee-for-service towards more value-based care, is just quite astounding. It's one reason why I think in New York City now, there's only about 25-30% of doctors in the city not owned by a big hospital system. It's become harder and harder to be an independent physician and adhere to all the meaningful use rules and things like that, even if you want to do those things, and not be gobbled up by a big hospital system that gives you the help to do all these things. So we think as Oscar, we can primarily focus on making your life easier as a physician, and that is sometimes simple stuff like paying claims faster. We can pay claims in about 3 to 4 days. Most insurers pay upwards of 2 weeks, 3 weeks or so. We, in our work with the Cleveland Clinic, where we built a co-branded insurance plan, we share risk 50-50. We got rid of what's called prior authorization rules, so physicians don't have to jump through a bunch of hoops to get certain procedures authorized.
Yeah.
These are all things you can do if you have a better relationship between the physician, the provider, and the insurance company. And that's one big angle we focus on with physicians. The other one is to extends a more seamless member experience also into the physician office, and try to make sure, again, we look at this from the angle of what does the end user think of Oscar in terms of how seamless the experience is. And that relates to scheduling into your EHR system as a physician. It relates to giving the physician a better ability to route care into specialists and know where to route members and things like that. And that's another big work stream. Yeah,
and I think another kind of differentiator as a health plan is that you actually have a bricks and mortar facility in Brooklyn. My understanding, it offers primary care services, but then also some wellness services, yoga, et cetera. So where does that fit into the broader strategy? Why was that important to have a bricks and mortar presence?
I think for two reasons. Actually, mostly for one reason, which is it is an experimental laboratory for testing out what we can do when we're in the provider practice. That was the first practice where we extended the ability for our concierge teams. These are the 6-person teams, one of whom is a nurse, that cover you as a member, right? Whenever you talk to Oscar, there's 6 people that'll pick up the phone, chat with you, your concierge team, and they have more visibility into your data. You get to know them better and things like that. You see their pictures and their names and all that kind of stuff. And this clinic in Brooklyn was the first one where we extended the ability for the concierge teams to engage more directly with the physicians in that clinic. Obviously, they're our own physicians, and so we can tell them how to interact with the concierge teams. And that was a good test laboratory for something we might now roll out, kind of 3-party messaging, concierge team, member of Oscar, your provider, in kind of one chat, into other practices we now work with more directly as well. So generally, we see in that clinic what we then would roll out in other practices later on. It's part of the overall, I think, philosophy and expectation of what's happening in the healthcare system, which is that I increasingly think the delivery system is unbundling. Less will happen in the hospital, less will perhaps even happen in bricks and mortar clinics. If we look at the average 25-year-olds, Oscar in New York now, they use telemedicine, they use urgent care. They oftentimes don't even have a primary care physician anymore. They look at a city MD, let's say, as a primary care physician, which isn't, I think, the way it should work. Don't get me wrong on that. I would prefer for people to have a primary care physician in person or in the clouds both can be possible in a good way, but that unbundling is happening, and so having a way to experiment with how that could look, how that could work, is powerful.
Yeah, and I wanted to ask, because obviously you've integrated a lot of telemedicine services, and when you think about all of kind of connected care that's being shifted into the home, the whole point of that is to reduce downstream utilization and help us kind of bend the overall cost curve. So what has Oscar's experience been when you look at kind of your cost data?
Yep.
How does telemedicine, remote care, kind of driving care to lower cost care settings, is that becoming a reality for you guys?
Absolutely, and I think it's coming in from all kinds of different angles. So a couple of different data points. We now care routes about 40% of Oscar members' first-time physician visits. So if you look at, from the claims we see, who is going to which physician, obviously, and we can also see from the claims code when this is a first-time visit versus a recurring visit. If we look at the first-time visits and we kind of go back before that visit occurs, about 40% of the visits are of members who use the app, use the concierge team, use the websites to find that particular doctor. And when the way we get members to these doctors, we are able to get them to, on average, doctors that drive 10%, 11% lower total cost of care for the episode of care that they will kick off with their physician visits, as compared to if they went to a random doctor in our network, random comparable doctor in our network, okay? And at the same time, the member experience score is about 9% better. So this is a unique healthcare thing that you can actually get both lower cost and higher quality right. In this case being, member experience being an approximation for quality. It doesn't always work, but it's one of the elements in there, that you can get both of these at the same time. If you multiply that out, this year in 2018 is probably taken out about 0.5% of our medical loss ratio. Okay, so our overall claims costs fall by about 0.5% because we get members in the first-time physician visits to doctors who on average drive 11% lower total cost of care, okay? On the telemedicine side, that's now, for us, when we look at all episodes of care, so episodes is a word for, we built our own internal grouping mechanism, algorithm that takes claims and labs and drugs and so on and bundles them together in logical chunks of this belongs to the same disease states you try to solve as a member. That's an episode basically. Of all of our episodes in 2017 now in this case, 1 out of 6 was telemedicine. Okay, so that's become a fairly large chunk of what we generally do. And even if we assume that about 50% of those episodes are induced demands, meaning you had a flu, you otherwise, if you didn't have a telemedicine doctor easily on tap, you would have just stayed on the couch and done nothing. If 50% of that would have been excess utilization, we still take out about 0.3, 0.4% of the medical loss ratio by shifting away from the system towards telemedicine. So those are 2 utilization examples. On the very heavy end of care, on the complex care end, we've got about 150 or so of our patients in specialized concierge teams that have more discretion on how they invest members' healthcare outcomes. So, and they get dedicated towards the most complex members we have, members who would go back to the hospital once a week, congestive heart failure or something like that, if we didn't follow up with them very closely. And there we probably take out about 15-20% of the costs by just doing things like building a ramp in somebody's house when the member otherwise couldn't get discharged from a rehab facility and now can go back to the home and live a more comfortable life there, or making sure we follow up every single day with a member to make sure that the weights is controlled in a good way and things like that. One more example would be in a totally different camp, which is just internal operations. On the claims side, I mentioned before we pay claims more quickly than other insurance companies. About 93% of claims are now auto-adjudicated. That means they come in, no human being has to look at the claim. It just runs through the system automatically, basically. That means we have less human sort of like labor in having to go through that entire process, and actually probably lower error rates than compared to before as well. And on a per member per month administrative overhead basis, when we compare what we pay for the act of doing claims adjudication to what other insurers pay for it, we're probably already 0.5, 1% below of where other insurance companies are. And now, some of these things might sound like small numbers, but don't forget that the average insurance company's MLR is something like 86% or so. and the average profit margin is about between 2 and 3%. And on that basis, it becomes pretty meaningful. And I really do think we are very early on in rolling in sort of like in dialing all of this up in even more meaningful ways.
Thank you for all the questions that are coming in. Keep them coming. I'll try to pepper some of those in too. So one that's been voted up a lot is, what are some examples of digital health products, especially in the behavioral health space, that Oscar Health reimburses? And why did you decide to include them as a benefit?
That's a great question. So we have not done as much as I would wish we would have in mental health. We have that's one of the few areas where we still have a vendor delivering essentially the mental health care. Won't say who it is, but it's a big vendor. You all know it, and there is. Let me put it this way: there's a lot of opportunity there. We find ourselves having to do a lot of work in double doing and staying on top of what that vendor does with our concierge teams to make sure members really get the best possible experience in getting mental health care. I think one thing I've observed in mental health is really that a few years ago, you started having the first sort of like apps that were a bit more on the outside of the system. They're trying to measure through mobile phone utilization whether you're entering a depressed state or anxiety states, and then giving you direct alerts, customer alerts about this. Many of these players have now morphed more towards actually building mental health delivery networks, care delivery networks. And I, for one, am really looking forward to when we can start switching into that and utilizing that directly. We are going to do more in telemental health very shortly ourselves internally. We have a couple dozen physicians now at this point delivering our own telemedicine generally, and a few of those will become telemental health physicians very shortly. And so there's a pretty wide open field there, and it's important. One of the highest search terms in the Oscar app is anxiety and is a depression disorder, and so there is a lot more we need to do there, I think. Yeah,
this is probably a good point to ask you about how Oscar thinks about kind of the rest of the digital health kind of startup innovation ecosystem. I think Oscar, historically, you've built out so many of your tools yourselves. So how do you, and I'm just thinking there are a ton of behavioral health startups, probably some in the audience. How do you kind of think about where you integrate some of that innovation with what you're doing at Oscar?
Yeah. So early on we started, I think I may have told this story at some point before, but I sort of thought, my background's computer science, I thought, okay, we can build a health insurer like you would build a software project. You find the right cloud provider, you find the right kind of other vendors you tap into, you get the APIs and you roll it out. And in fact, actually, one of our earliest vendor contracts we signed, again, I shouldn't say who it was, but it's another big vendor that does like a thing that every insurance company needs, has had in that early contract a whole appendix of API calls we would supposedly be able to do. And I remember reading the API call just like list and thought it was a bit odd as to how they were named and things like that. And long story short, those never existed. They were literally cooked up by one engineer somewhere in the bowels of that big behemoth that tried to deliver this thing, and they actually never were real. And so to this day, I don't think that many of the core infrastructure components of what you need to do to deliver healthcare and deliver health insurance as well. And we generally look at ourselves as delivering healthcare, not health insurance. They're not API-ified, and they're not sort of like technology-friendly vendors in the space where you can really say, okay, this guy is going to be excellent at delivering the service, and I can just connect to this person and let him do that service. Right. Okay, so you won't find the equivalent of, let's say, a Google TensorFlow, or whatever, in healthcare, in a sense, in a healthcare service environment. And that led us to really say we've got to do all this stuff in-house. And again, that goes back to being a full-stack insurance company and all the advantages we think we get with that. Now, two things I think are in my mind now. One is that world is changing a bit. As I mentioned before, on the mental health side, more of the mental health digital solutions now builds mental health delivery networks. That's, I think, powerful because it makes it more tangible to be able to tap into them and connect to them. And so I'm looking forward to doing more of that for sure. And the second thing, really also is that we have a lot more of the basic building blocks now fully under our control. We can more directly now really say how we can connect to a third party in real time and make sure we build that into our benefits, make sure we experiment around how we would reimburse that and things like that in a way that wouldn't have been the case had we still been going through third parties on the claim side, the network construction side, and things like that. And so you will see us do more with digital health solutions in the future that we have done traditionally in the past. I think it's very powerful, and I think we can be one of the best in making that happen and enabling that ecosystem for sure. Yeah, I'm looking forward to ideas there. One thought there actually that I found interesting, and sometimes when people ask me for advice on this, I give them the following advice. Because insurance companies that have traditionally been the gatekeepers on digital health solutions, because they are the ones who ultimately got to pay for this thing. Right. And the other sort of like payer oftentimes is the employer, right? Because both of these have sucked, excuse my French, at user interface and user experience. If you were a digital health player who came at this from a clinical side, you thought you have a unique clinical solution, you found yourself oftentimes in a situation where you have to build a better user interface first, even though you wanted or like a better EDI integration for eligibility checks and claims and whatever else, even though you wanted to focus on your clinical solution. And so I hope we're heading into a situation where certainly at least us can say, look, we've got the member experience already, we've got the member facing assets in a way that you should be able to tap into that. So please, from my point of view, focus on the clinical logic behind it. I'd be happily paying you for that, and less so for the user experience, which we can build just as good, if not even better, because we have more data about the user and are more directly engaged with the user directly.
That's super interesting, because yesterday there was a conversation on AI about how it can't just be about the algorithm. The algorithm is the first step. Then it's about kind of integrating it into whether it's the clinical workflow or the user experience to make decisions. But what you're saying is you've thought about that. You've thought so much about the user provider experience that actually it's some of the back end clinical decision support or other support that could be really valuable.
Exactly. In fact, I think that's probably the single biggest and most important thing we have done. The fact that now 40% of members of Oscar find their doctor through Oscar, first-time doctor through Oscar, that is, by all accounts that I have, is about 10x away from what other insurance companies are. We traditionally have had 10x telemedicine utilization versus anybody else out there. Again, the 1 in 6 episodes telemedicine, the other way to look at this is that for routine conditions like conjunctivitis, about 2/3 of those episodes now have a telemedicine encounter as part of the episodes. So we've solved, I wouldn't say we've solved, but we've made huge strides in that end. And we would much more happily pay people for smarter clinical routing and insights and very pointed engagements than necessarily for having another solution run at the UI. Now, I do know that as you're selling your service, if you're a digital health provider, that's not what most other people would pay for this, the situation that they have. If you're an employer, you're sort of like, put everything together in a sense, right? And then,
I need the whole solution.
You've got the issue that none of these things really talk all that well. But I do hope more of the system will look like the one we have provided, and you can link more easily into that.
Yeah. Okay. Well, let's talk about growth, because we're getting some questions about the kind of Alphabet's investment, how that supports your work, and I'm going to kind of piggyback on that with my question around, You've said you're going to enter the Medicare Advantage market, so that would mean that you're kind of in the individual exchange market, the employer market, as well as moving into MA. So thinking about how the Alphabet investment is going to propel your growth and how you see those kind of three business lines growing, how are you balancing all of that? So
these are, in my view, the markets where we are the closest to the individual, which is the most critical part of our model. The individual market, obviously, you're signing up individuals who pay out of pocket directly. In the small group markets, we sell to lots of kind of 5-person groups, smaller groups on the lower end of the spectrum in terms of group size. That's still pretty word of mouth and individually sold and engaged. And so that's great again as well, because we can engage members directly when they sign up with Oscar and make sure that they really have a good experience and things like that. And the MA market is obviously the other market where individuals can buy directly from the insurance company, really. And so that has always been the long-term plan, to be in those markets. And by the way, the other part of that plan is that I fully expect and I fully hope for I think society's sake, and for everybody's sake in this room as well, because I'm sure many of you have digital health companies of your own, that the rest of the insurance markets will individualize over time. There is movements in DC around finding more ways to let employers give pre-tax dollars to individuals. then let those individuals choose which plans they want to buy as a result, whether they're buying the exchange directly from brokers or from our website or whatever else. And I think the more this system individualizes, the better it will be for all of us. The more competition will be on the value chain, on the insurance companies, on the hospitals, the more competition there will be in building different delivery networks, the more honesty there will be and necessity there will be in tying what people pay out of pockets to actually delivering better outcomes and lower costs. So I think that's the other sort of like thing in the back of my mind, that even the large employer markets will individualize over time. And I hope it's not a 10-year thing. I hope it's like a 3-year thing. So now that's how we think about the markets we generally want to be in, individualized, so we can engage individuals directly. MA, as a result, is something we always wanted to enter. And we just had to pick the right point in time. And with Alphabet coming in, that gave us another good amount of capital, obviously, to go and put the required reserve capital on holds and make the investments on the compliance sides, on the network construction sides, to go and build those products. I think many of the things we do, concierge teams, our own telemedicine solution, everything we're doing in risk adjustments, that's an odd part of what insurance companies do that we can talk about in a little bit as well. Those are all highly applicable in the MA market as well. And we have a couple of thousand members actually aging out of Oscar who turn 65, 66 every year, who directly go into our MA market once we roll it out. And so I'm glad we can now finally go and do it. And we're a couple of weeks away from tying down the markets we want to be in for 2020, and we'll be in by 2020.
I was telling Mario, hopefully he'll be in LA by the time my mom turns 65 so she can stay on.
It's an extra motivation to be in there.
Another question that was voted up, so how do you recruit patients to join your network?
Patients or doctors?
Patients.
Patients. Okay, so we sell in open enrollments every year, meaning in the exchanges, open enrollment starts generally November 1st. In California, starts a bit earlier, that's what I just mentioned. And it generally ends December 15th. And so we've got this very odd growth pattern for, I think, any venture-backed company where we can really grow. We really grow once a year, and we then generally grow pretty explosively. And we're also, and this is also just all very different than I think what most of those companies face. Right now, when I look at our open enrollment dashboard, we've got a real-time dashboard that tracks all the sort of like flows that come into Oscar. It goes back to 0 at the beginning of each open enrollment periods, which is sort of like a crazy thing to think about. You really have to re-enroll the entire membership base. For us now, about 250,000 members this year, and then some, of course, to keep growing. That is anxiety-inducing on some level, because you got to really show up and make sure that all works, so the experience is good, the members want to come back to the plan. The timelines are crazy as well. Right now, we're in the process of tying down everything for 2020 and even 2021. I don't think there's any other technology-backed startup that has to plan so far in advance, and has to close provider deals, get regulatory filings in place, and plan out so far in advance to really make sure you keep growing year over year. That's all the things that are crazy about insurance, basically about health insurance. I don't see any other solution, frankly. I think it's just kind of the way it has to work, but that's the way it currently still is. There's a little bit of a thing where you sometimes see these sort of like hardware and software limitations that unduly make their way into the way the markets operate. For example, if you really think about it, there isn't a great reason, there's a very good reason why you need to have an insurance plan for a year. If you could just sort of like come into insurance and pay a month of premium when you're sick and then get out again, that's not insurance. I don't know what that then is. It's like a discount plan or something like that. That's how your dental plan works a little bit. So that's why you need to have a certain period of time there. But there isn't a great reason why it needs to be tied to the calendar year. It should be more up to you as to sort of like when you come in and when you buy it and when a company buys it. And we should have some more flexibility, I think, the pricing side perhaps as well. In New York State, for example, even in the employer markets, where companies can actually, they actually are able to sign up throughout the year. We can only redo our pricing once a year. In California, we can do it on a quarterly basis, but it has to be 2 or 3 quarters in advance. If there was some more ability of saying, we are seeing that we overshot on the risk we expected in the market, we could take our prices down. Or we are seeing a new feature that we launched is taking more cost out than we anticipated, let's get more members onto this thing more quickly. These are price decisions you can't really make in health insurance and in healthcare. Again, to some degree, in good ways. You don't want too much sort of like pricing volatility in insurance markets. But to some degree, I think in ways that it holds the market back from being more versatile and more nimble.
Let's get another one from the audience. So let's see, how does Oscar Health deal with chronic diseases such as diabetes in clinics and for the providers in patient treatment? Let me try to rephrase. So how are you helping manage chronic disease?
Yeah, that's what we primarily built the concierge teams for. So the idea behind the concierge teams was that we used to have traditional insurance setup, which is you have a customer service team over here, and you have a team of nurses and clinical agents essentially over here. And then the clinical people would have certain protocols, they would engage in certain points at certain points in time, and they would sort of like take over from the customer service agents and say, this is a member who I should manage, give me the member, and I'll help the member get the medication, manage their chronic disease and things like that. That's how most health insurers operate. I think the other part to this, to me, is that much of the health insurance markets is actually an ASO markets, where employers pay just a monthly fee to an insurance company, but the employer still carries the risk. I think that's a crazy setup, frankly, that makes the employer do something that they have no idea, frankly, how to. That's not part. I wouldn't say they have no idea of doing it. They're good people in HR departments and that try this very hard, but it's not part of their core competency as an employer. Not anymore, at least. You know, in the days of where we all work for the same employer for decades, maybe you could make an argument there, but that's just not the case anymore. And so, as a result, many insurance companies that build disease management programs, at least from what I can tell, build them oftentimes as revenue opportunities. They can charge an employer extra on a PMPM basis, per month basis, to try to deliver an experience there that was not sort of like stringently connected through all the way to whether there really is a cost outcome. And so that's not really something that makes a lot of sense in the individual market, where people pay out of their own pocket and want to see that you're giving them a good experience on the one hand, but they're also having a better impact on their own out-of-pocket costs and managing their diabetes, for example. So what we ended up realizing is that many of the questions, when there's no safety layer between us and the member in the form of an HR department and a bunch of brokers and a bunch of benefit consultants, all the stuff that's in the middle there in the employer market oftentimes, then our customer service agents end up fielding lots of questions that look like they're not clinical, but they should really be clinical. And my favorite example is always when you ask us about your benefits or about a deductible on the phone or chat, whatever else, you will have a 70% chance of having a claim within 3 to 4 weeks. Not surprising at all, right? I mean, you're calling about that because you're probably thinking about going to the doctor. And so then the conversation right away should be, well, are you planning on utilizing? What are you going to do there? Can we help you with finding the right doctor and things like that? That's how our concierge teams came about. 6 people covering you, and people around you in your geography. So my concierge team at Oscar, for example, covers the Upper West Side and kind of Midtown Manhattan. You know, we've got a couple of thousand people in there. That way they get to know the subway lines, the physicians who we can route to in the best way and things like that. And one of these 6 people is a nurse, and so they can manage you more closely directly there. We separately do have a population health team that runs clinical pilot programs in a more rapid scale across using the concierge teams and using the app. And so they, for example, do things like medication adherence. The nurses get events and alerts that are driven by the data we have. So the nurse on the concierge team would get a ping that says Mario hasn't filled his metformin prescription, for example, in a certain period of time. Therefore, reach back out to him and make sure he can fill the prescription, or find out why he isn't able to fill the prescription. Is it a finance issue? Is it something else we can do about that? And the nurse can then go and do that. So, long story short, through the concierge teams, we manage the chronic diseases. They don't get farmed out into separate chronic management teams. And then, as I mentioned before, we do have several concierge teams that are complex care management teams that take a couple hundred at this point, I think, of the sickest members we have. And they get identified through our clinical algorithms we wrote, where if we start seeing certain lab tests coming about you, certain drugs coming about you early on, we sort of like, and even the way you filled out your own surveys when you onboard, we get you onto those teams and they can manage you much more in a hands-on fashion. And they deliver home visits as well. We have some social workers there that work directly for Oscar. We enlist some of our providers' help directly as well. We know which provider groups in our networks see many of these patients. We use the Brooklyn Oscar Clinic for that as well, and so on.
Yeah. So I wanted to zoom out and ask a scalability question. So when you think about kind of scaling the Oscar model, going into a new market takes a lot. I mean, you have to build a new provider network. You need to kind of advertise Oscar and become a known name to your potential patients. You need to, build relationships with brokers and so on and so forth. Those things don't feel particularly scalable. You're going to need to do that in every market versus all of the software that you've built, the user interface, the app. That feels very scalable to me. So I wanted to hear you talk a bit about, when you think about your growth, what are the kind of scalable components of Oscar, and then what requires kind of the same amount of effort each time?
Yeah, very good question. So it as mentioned before, it takes us a long time to go into new markets. It requires about, I'd say, 2 years all in of upfront management and planning and so on. At the beginning of this year, we started running our internal algorithm that we built to select the next markets we want to go into. It uses network competition, insurer competition, demographics and things like that and penetration of insurance plans to tell us which cities we should go focus on. And then we go and identify hospital networks and physician groups we want to talk to about building selective network designs. Our model is to really, in all the cities we go into, only build selective networks, generally built around a particular health system or a physician group and things like that. And again, the Cleveland Clinic model we talked about before is, I think, the most powerful epitome of that. So we share risk 50-50 and we have deep integrations with them and things like that. If I compare what we do today to what we were doing a couple of years ago, when we also used a couple more of the traditional levers a couple of years ago, a lot more of that is actually automated, but automated in support of human beings doing the work. Okay, and so the way we build networks is we identify through all kinds of data we can get on the claim side and so on, which physicians in a given geography we should get into the network. We try to get early reads on physician quality, physician costs. We have our own algorithms internally for placing physicians, basically, that tell us across 350 different specialties how much utilization we expect in a given market, and therefore how many cardiologists we need and where we need them, using driving time, things like that. When the claims start coming in, we start getting very early reads on availability as well. We have a team that just makes outbound phone calls and looks at sort of like member feedback and customer concierge feedback as to how difficult it is to schedule appointments with certain physicians. That then tell us where we need to augment the network, where we have gaps and things like that. So every day, actually on a real-time basis, but we look at it once a day, all that stuff generates lists of potential network holes where it takes too long to get an appointment, or a particular specialist, oftentimes maybe an obscure subspecialist, isn't in the network in the way we need it to be. And then there's a process around then signing single case agreements, getting you access to a physician quickly, even though the physician on the network, and then over time filling that hole. And that data still gets pushed out to people in the fields. So we have people that descend on a city that go and make do physician contracts basically, and hospital contracts, and that still is a manual process to some degree. We are getting to the point where I think we can essentially connect this all the way through in a better way, where it's conceivable that we go to a physician and say, here's an iPad, and just kind of like take up a couple of sliders, tell us the contracting parameters you want, and that gets configured directly into the claim system. One of the cool things these sort of like pinnacle actually usually of my demos towards hospital CEOs. When we build networks, we try to still, really go to a hospital system CEO and to the management team and to the clinical leader of the hospital and say, this is what we do, and this is how it looks. That's about a 2-hour demo that I give. It's the member experience, it's the back office experience, it's how we integrate with providers and things like that. And the end of that demo is that I go into Ocelot. That's our new claim system. You gotta ask the engineers why they give funny animal names. It's Muppet Street, it's Sesame Street names, and it's animal names for some bizarre reason. I go into Ocelot and I on the fly reconfigure and recompile our claim system, and I put a little benefit in there that's basically pays the provider 0.5% more when a provider doctor makes an outbound phone call or chat, whatever, after a member went to an ER. So like a nice little claim that connects a bunch of different data points. And I recompile it and I re-adjudicate a claim, a real claim that then kind of gets shown on the screen and how this looks before and after. And that is usually sort of like a nice way to hammer home the versatility we have and what we could do with the provider system. And in other words, that system now of having essentially a programming language that we built in-house, a domain-specific language to configure benefits and claims, we could extend towards even the networking contracting stage, where one of our people goes to the doctor and says, program the contract for me, kind of like dial up and dial down the things you want in there. There's a risk sharing in terms of whatever else we pay you for telemedicine engagement and stuff like that, and then gets configured all the way through. So the pieces are in place of that. That connectivity is not yet there. I think the next 18 months probably will be there as well. But long story short now, long story I just told, lot more automation in doing all that, but oftentimes the automation is in guiding humans and our people basically in how they should go and do these things. And the automation that to some degree was available in the existing system before. There are geo-access tools where you can say, do I have a sufficient network in a given area? The regulators actually run those as well. We found to be deficient in a situation where you want to build different network designs, where you have individuals who got to really find doctors and things like that. It wasn't until, I'd say, a year or 2 years ago that the regulatory bodies on the state level and the federal level started fining insurance companies for deficient online provider directories. It's a very new thing. The early studies from 2 years ago, early studies, showed that about 30-40% of insurance companies' online provider directories were just simply wrong. And so to me, this always kind of meant that a bunch of these sort of tools that were available in the industry for doing some of the stuff were just not really built for a better member experience, but for crude approximations of just kind of barely keeping the system working. And so that we had to overcome.
I know we need to wrap up, but I wanted to give you a chance to kind of rapid fire tell us, what advice do you have there's a lot of entrepreneurs, innovators in the audience, what advice do you have for them?
Yeah, I think one is I'm glad so many people are really now working on digital health. I think to me, seems like an unbelievable fever curve. I think that's a few years ago when we started in 2012, to me, there almost seemed two different healthcare systems. There was the healthcare system that cost us $3.5 trillion, whatever it is now, and there was a Silicon Valley infused healthcare system was building solutions that ideally would have entered and replaced the system, but weren't connected that well. I think there's much more connectivity there now, and I'm glad that we're one of the ones who were able to become the ultimate insider in the existing system and kind of work from the inside out. And as much as you can, I think I would encourage you guys to find ways to work from the inside out of the existing systems. I would, in the end, really always follow the money. The problem still is that much of the US healthcare system is essentially a cost-plus system. If you've got a great solution that lowers costs, there are not many people in the healthcare system whose business model and P&L right now is to lower costs. If you go to a hospital and want to lower their costs, in a fee-for-service world, that doesn't really help them that much. They sort of want to keep the reimbursement rates high, and you'll find, I think, resistance there in the end in trying to lower, ER visits, or in trying to keep care out of the facility and move it into ambulatory settings and things like that. And so you got to find the ones in the system that actually are able to, where the business model is more directly lower the costs. I'm not even so sure how true that is for the employers nowadays. Big employers, in my view, still way over-index on not upsetting people around giving them different network designs and things like that, even though clearly that's important for the cost and can get to better quality outcomes. And so the more I think we all can, the more we should be pushing for slicing, giving individuals a chance to take their own dollars, maybe funded by the employer, and take that to wherever they want to. I think that would be good for the entire system. It creates opportunities in unseating the incumbents. That's going to be important. I think the other important one is keep your head down and watch what's happening on the regulatory side, but don't get freaked out by it. In the end, there is an inexorable inevitable march towards individualization in healthcare. I think whether Democrats talk about Medicare for all, which I think will morph into Medicare Advantage for all, or the Republicans talk about whatever block grants and stuff like that. In the end, all of these things with sort of different underlying assumptions about human nature, I think, which we can certainly argue about. They all, again, lead towards giving individuals more of a chance to have a say in this. And ideally, you can't make somebody who's undergoing a complex disease a fantastically educated healthcare consumer. That's difficult because you have lots of other emotional load on you when you navigate that disease. Yeah. But I think what it mostly does, it will put more pressure on the value chains, and that's very important in giving individuals more choice, and that's really what we need. So keep your head down, sort of like know that I think over time we will hopefully end up with a better regulatory framework, and I don't think people will be crazy enough to, I don't know, turn back the clock on the 50 million people who've gotten, actually probably the 25 million people who've gotten health insurance coverage in the last 4 years since the ACA came out. It may be called different names, whatever, but it won't get turned back the clock on that. So I think that we can be pretty confident about as well. And finally, I think in navigating the regulatory landscape, one advice I have there is that I do think healthcare regulators are people who want the best and want to do good public policy. And you should build that into your assumption as to how you interface with them. They're not trying to sort of like keep you down or not let you do the things you want to go and do. They want to get to a better system. None of them really likes the system, but they have gotten used to players in the system acting in certain ways and have certain tools in how they look at these players, okay? And so that you got to sort of like understand. And in our case, I think one fun story was, not so fun, but an interesting story was that in our internal customer service systems, we let our concierge agents flag whether a call was like good or whether the member was unhappy. It was just a smiley face basically that you can slide up and down. And one of our state regulators said, every time you have an unhappy member there, you right away have to turn this into a so-called complaint and grievance, which is a very highly regulated part of an official way to complain about an insurance company. We have to report to regulators and things like that, which we of course do very diligently. But not every unhappy phone call is a complaint and grievance right away. Mm-hmm. We just follow up on them right away. We try, and then there's a supervisor calling you back or whatever and trying to help you with the issue and stuff like that. So that didn't really make a lot of sense to suddenly connect those two things. But that was the regulators basically using a tried and true way in which they try to manage insurance companies who weren't in the game for improving member experience and make sure they're good actors. And once we explain to them what we actually accomplish with this thing, they're like, okay, now I get it. You're trying to get to better member experience here. It's a good tool for you. You should have explained that earlier, basically. So, long story short, work with the regulators, respect the rules, fight for better ones. You'll find them open, but you gotta pick them up where they stand and explain to them in their words, in their frameworks, what you're trying to get done, and then I think it'll work very well.
It's very good advice. Thank you so much, Mario, for being with us, for sharing your insights. We're excited to see where Oscar heads.